Welcome back to OpenLine tonight. We are talking about ovarian cancer because September is Ovarian Cancer Awareness Month. If you missed the beginning of the hour, I want to throw some stats at you that probably make you sit up and pay attention. 1 in 70 women will be diagnosed with ovarian cancer, and it is the deadliest of all gynecological cancers. So something to be reckoned with. Dr. Cabelli here from Vanderbilt, and Marcy Huff, an ovarian cancer survivor and now advocate for awareness and research. Thank you both for being here once again. Dr. Cabelli is a doctor, a surgeon, and a researcher. I had a chance to be in your lab this past week. Can you put into real life terms that the rest of us can understand what you are doing in the lab right now? Because we were getting a video and you're like, well, let me pull out these cancer cells from the refrigerator. I was like, whoa, are you kidding me? Crazy.
Yeah. So what we do is we test new combinations of cancer drugs that we think will improve upon some of our current treatments. So that, for instance, there's a new drug that was initially FDA approved for women who have BRCA mutations.
Okay.
It's called a PARP inhibitor, and some of the research I'm doing in my lab is to combine drugs with the PARP inhibitor so that we can offer it to more women. They don't have to have a BRCA mutation, and they could derive benefit from that drug.
Gotcha.
And so we recently published a paper where we showed that this combination worked in the Petri dish, it worked in our animal models, and now we've written a clinical trial that we're hoping to open at Vanderbilt very soon so that we can offer this combination to women who have recurrent ovarian cancer, where the cancer has come back, and we're able to offer this combination to them.
Because I read that a lot, when it comes to ovarian cancer, a lot of women do not respond to chemotherapy.
Well, in fact, most women respond initially, but about 50% it comes back within a year or two.
Wow.
So the initial response is very, very good, and most women can actually achieve a remission, or a period of time when they're off of chemotherapy. So even if it's not curative, they get a good response and can come off chemotherapy for a period of time. Unfortunately, within the first 2 years of diagnosis of stage 3 or 4 ovarian cancer, more than 50% of women, the cancer comes back. So what we're trying to do is find out if we can combine different treatments so that women come back and get chemotherapy, but they're living with the cancer and living longer with it. We know we can't cure it at that point, but how about sort of maintenance chemotherapy, or something that is tolerable, or maybe we can get them into another remission. So that's the work that my lab is doing.
And you know, in the stories I'm going to do that are upcoming later on this week, we met a patient, and we actually met her during her infusion of a drug. It was not chemotherapy, it was a drug for melanoma. And it was part of a trial to be tested to see if this would also target the ovarian cancer. How amazing. And it's part of a trial that's happening at Vanderbilt right now.
Absolutely. We have cutting edge clinical trials. The wave of the future and sort of the edge of where we're going research-wise is that just because you have ovarian cancer doesn't mean your tumor may not respond to something that works for melanoma or works for breast cancer. So we have the benefit of having access to new chemotherapy drugs and immunotherapy drugs and new targeted drugs that are specifically targeting certain proteins that are specific to certain tumors. Those are all available at Vanderbilt, and that's the benefit of being at a major comprehensive cancer center.
Sure, so not only does she have hope that her life will be saved and that she can have a good life going forward, but that, you know, she can stay home during treatment. She can stay where her family is, where her community is. She's not going, and even spending the money to be in a faraway city. I mean, it all has a stressful impact on you, which cannot be good for your disease, right? I mean, it just makes sense. I mean,
so
we
offer all of that here at Vanderbilt.
It's amazing. It's amazing. What do you tell women when you have to sit across the table from that patient and say, you have ovarian cancer? What is the next step?
So that is a very difficult conversation. That's one of the hardest conversations, right? And part of the time, what I tell people is they need to bring people with them, because you need multiple sets of ears, because often you're not taking it in yourself.
You never think you're going to hear those words.
And so I think that what I tell people is that we have a lot of treatments to offer you. If it's stage 3 or 4, the chance of curing it is not high, but we're going to do everything we can that first shot to try to get it cured. If we can't, we have all sorts of options for treatment to follow that initial therapy. And what we offer at Vanderbilt is everything from preventing ovarian cancer with our genetics counseling and testing and interventions before you get the cancer if you have a family history of it, to initial diagnosis and treatment. And then we offer a lot when things don't work and the chemotherapy fails, and then people need supportive care and palliative care and end-of-life care. So we offer the whole gamut. And then obviously, you know, we have a whole space in between where people can come on a clinical trial if it comes back, and then we have standard therapies to offer if it comes back.
What should a patient consider when considering a clinical trial?
Clinical trials are important. They're a variety of clinical trials. There's some clinical trials where we're testing new drugs, where they're first in human beings kind of clinical trials, and then there are clinical trials where we're comparing to standard therapy. And it just depends on what drugs are available, and also the patient and family support, and how strong a person is to enter a clinical trial, because you have to have, you know, basically a lot of otherwise be relatively healthy in general to participate in a trial, in most trials. Good kidney function, liver function, your blood counts need to be okay.
Makes sense.
You need to be sort of functional, because you don't want to, you know, we need to figure out whether the side effects are from the trial or from your
Something
underlying.
else.
Yeah, so those are the things to consider.
Okay, very good. Michelle is on the line. Michelle, I understand you have a question about why there's no cure. Go ahead.
I do. I just had a question why after all these years that we're still just, we have actually not found a cure for cancer. I mean, we have so many drugs that are out here, and of course there's always drug therapy. Why haven't we found a cure after all this time?
You know, it's such a good question. I think that a lot of people have thought that, because we hear so much about every type of cancer. It seems like, why isn't there a cure?
Well, first of all, cancer is not one disease, okay? And what we're discovering is that cancer is hundreds and hundreds of different conditions, even in the umbrella of ovarian cancer. So there's some types of ovarian cancer that respond very well to certain types of drugs. And then there's some types of ovarian cancer that don't respond at all. So they're resistant. So that's actually a different subtype of ovarian cancer, okay? And we're only discovering this by looking at the DNA of the tumors.
Oh, wow.
And this is what Vanderbilt also has to offer, because we are able to look at the molecular profile or the DNA of the tumors to figure out what type of subtype of cancer this is, so that we can better target the treatment. So there's not one treatment for all cancer. And the complexity of it means that we have to keep doing research to figure out what specifically is going to work for an individual, because one size doesn't fit all.
Wow. Wow, that's just so amazing. And you have to put so much trust in your doctor, and that's why you said you've got to get to the right doctor.
You have to get to a specialist, because this is complex. This is not simple stuff.
This is not, you have ovarian cancer, here's what you're going to do, step 1, 2, 3, 4, 5.
And this speaks to me so much, because as I've been doing this in the past close to 4 years, I'm meeting women all the time that have been given this diagnosis, and many times they didn't end up in remission like I have. So I think, well, why is it I went through this chemotherapy and here I am, but they went through pretty much the same chemotherapy? Why aren't they in the same place? Well, it speaks to this notion that my cancer is somehow different, so you target each person's individual tumors, and treatment for one person isn't a blanket necessarily for the other person. And the recurrence has always spoke to me quite a bit. I mean, I feel like if you've been given a diagnosis of ovarian cancer, you get through this aggressive surgery, chemotherapy, what right is it that it comes back?
Right.
I mean,
come on.
And it comes back a lot. It comes back a lot. And that's when the women, the outcomes aren't nearly as promising when you've had a recurrence of the disease.
And that's the lady that we met on Friday, Jane, who I'm going to introduce you to in the next couple of days. This is her second bout with ovarian cancer in a very short amount of time, in just about a year time. But the trial that she's going in, she said, you know what, I feel like I can just make the infusion that I have to have part of my day. It's a lot different than chemotherapy that took 8 to 10 hours a day. She said it takes a couple of hours, out I go, and the side effects are not nearly as bad. She said, I feel really good. That's a huge difference from her first round with it. And I guess that speaks to the research.
Yes, yes. I mean, and that's the idea. I mean, obviously we want to cure cancer. Okay, but because cancer is so complex, we have to take little pieces of this puzzle and see how we can make it better in very concrete and specific ways. And some of the ways we're doing this is by combining drugs that people didn't think could be combined, improving current treatments, trying new treatments like immunotherapy, which is not chemotherapy, but it's a way for your body to sort of charge up your own immune system to fight the cancer. And that's very exciting, new type of therapy that's being offered at
Instead of the
Vanderbilt.
chemo trying to kill off everything, you're trying to build up the good
Yes,
stuff.
exactly. So these are, and then I spoke to earlier, molecular targets, really looking at the DNA of the tumor and seeing if there's something out there that can target what's driving that tumor, sort of shutting it off, blocking whatever's driving its growth.
When I hear you talk, I can't help but think, I am so thankful there are extremely smart people like you in this world. I mean, seriously, isn't it amazing? Because you are in a realm that I could never imagine being, and I am so thankful that there are people who are interested in this sort of thing and dedicate their lives to it. And it really is a dedication on your part.
It is a dedication. I mean, you asked me earlier, what does it feel like to sit across from somebody and tell them that they have this diagnosis? I mean, this is what's driving what I do. Because it is very difficult to sit across from somebody and say, you know, we've tried all of these things and now we're coming to the end of the road. I'm going to be there with you to the very end and do everything I can to help you and prevent suffering and pain. But that is a difficult conversation. And so a day like that, I have to go back to my office, shut the door for a minute, and then I go to my lab. And I say, guys, what are we going to do here? We got to do better. And so that's really the driving force behind why I do what I do. Because, and then I look at somebody like Marcy, and I think she is absolutely incredible, and she's such an inspiration. How could I not get up every day and try to do what I do, you know, on her behalf? So,
Well, we have a mutual respect and admiration. I'm just glad I get to listen to the smart Dr. Cabelli as much as I do and learn.
And Marcy, it's fantastic that you've gone from the mindset of, okay, I'm in the fight for my life with a little bitty child at home and a husband you love dearly, I know that, but you've gone from that mentality to survivor, like, yes, okay, I'm in a good spot, to now I'm going to help other women. What's your message when you talk to other women? What do you say? What's the first thing you say?
If it's somebody who's going through what I've been through, I really just try to say, hey, I'm here and I'm living life and you can get through this too. Because I know when I was given the diagnosis, it wasn't easy for me to find somebody that I could relate to. So I want them to just see someone that's living their life and it's all quite possible. I obviously preach the signs and symptoms a lot, knowing that sometimes some women don't even present them.
Yeah.
But I think so many times women will say, well, what are the signs and symptoms of ovarian cancer? Which sometimes surprises me because, of course, I know what they are.
Right.
But a lot of women still don't know what they are.
And they're so easily explained away. Let's show again. We have a list of them. I know our producer will take just a second to pull those up. But they're so easily explained away, so I don't want you to just discount these. These are persistent, right,
Yes,
Dr. Cabelli?
these are persistent symptoms that happen over weeks to months. So the bloating, the pelvic and abdominal pain, difficulty eating, feeling full quickly. You've eaten a little bit and all of a sudden you feel full, change in bowel or bladder habits, and then irregular vaginal bleeding.
Okay. So don't explain them away if they continue.
Right.
And you know, and this is, and I'm not just, I don't want to just speak to the women and say this is your responsibility, because often a woman will complain to a man in her life and say, oh, I'm so bloated again, or, you know, I just so constipated, or, you know, and he can step up and say, you know, you've been complaining about this for a couple of weeks now.
That's right.
It's time to pay attention to this. Go see the doctor.
Yeah.
And if you're not
That's great advice.
satisfied, keep seeing another doctor, right?
That happened a little bit for me.
Did it?
Yeah.
Yeah?
I don't want to hear about this anymore. I've been hearing about it for a while. You should go see your doctor. And I did.
Yeah.
So sometimes you're right. It just takes somebody else kind of saying something to you.
And let's talk about this. Is it the CA-125, the blood test?
Yes.
Okay.
Yeah.
What's the deal with this blood test? It works, but it doesn't.
All right. So unfortunately, like I said, we do not have reliable screening for ovarian cancer. We don't have a screening test. What we use to diagnose or detect ovarian cancer is a combination of signs and symptoms, examination, a transvaginal ultrasound, and then a CA-125 can be drawn, and it's sometimes diagnostic, meaning it helps us make decisions to get further testing.
Okay.
The bad thing about the CA-125 is, especially in premenopausal women, it can be elevated for other reasons. So it can be an abnormal test because you have an ovarian cyst or you have something that's not cancer.
So it could give you a false positive.
A false positive, exactly. And so there was a huge study done in the United Kingdom that just got published this year where they screened thousands, tens of thousands of women in the United Kingdom. And the early results, I mean, the data are still coming forward, but the early results show that it didn't do any better than not screening. And in fact, they had to do 10 surgeries that didn't show ovarian cancer to find one.
Oh, wow.
And then they missed some cancers. So, you know, they're still continuing with the study, and they're still trying to analyze the results, and those results will come forward as the years, you know, progress. But right now, and the FDA has been very clear, and we're trying to get the message out to physicians as well, that really we don't have good screening, and don't use these tests as screening the general population. You really need to work with each individual patient and woman and figure out what her symptoms are, and then order these tests based on, you know, the symptoms and making a diagnosis. Just don't order them generally for the public.
Okay, because it may not be helpful at all.
It may not be helpful.
And could be pretty scary.
Right.
Yeah. Okay. We're going to take another quick break. Again, if you have a question, we have one more long segment coming up. So if you have a question for Dr. Cabelli or a question about one of the fundraisers coming up for Marcy, give us a call right now. You got one more segment to do it. Stay with us.